welcome. This is the session on access to care and impact of policy on treatment for children with autism spectrum disorder. So if you find yourself in the wrong room, now's the time to leave. But I'm glad you guys are here. I'm Doug Leslie. I'm at the Penn State College of Medicine, and I'll be chairing and also presenting in the symposium today. So we've got three, I think, very nice presentations, and then a discussant. So the first presenter, and I'll let you guys kind of do your own introduction so we can get right to it, will be M.P.H from the University of Arkansas. All right. So I've asked each of the presenters to limit their comments to 20 minutes, and then that should give us time at the end for any kind of general discussion.
Good afternoon, everyone. Thank you for being here. This is the last session of the conference, so hope you enjoy our session. I'm M.P.H from the University of Arkansas for Medical Sciences College of Pharmacy. I'd like to thank Dr. Leslie for organizing this session. And today, I will present a project on self-reported utilization of intervention by toddlers and preschoolers with Autism Spectrum Disorder. And also would like to thank my colleague who will be here as well, Nick Tilford, as a co-author on this project. So I think you're all aware about the prevalence that has increased in the past few decades of children with autism spectrum disorder, which increased a huge demand for effective intervention to address the impairment and also the associated condition with the ASD. The current evidence on early intervention that improve outcome suggests that the early intervention should be delivered in an intensive, which means more hours, approximately 15 to 25 hours per week at least, and also in comprehensive manner by addressing numerous areas of functioning. However, the evidence also suggests several important gaps in the literature. When compared to adult mental health condition, there's no research that describes outcome in relation to guideline concordant care in ASD. This may be because lack of evidence on recommended services, need for children with heterogeneous characteristics, and also we know very little about the actual percentage of children with ASD who receive services in relation to their demographic and clinical characteristics. Therefore, this study, we aim to describe the utilization of intervention for children with ASD before they turn 6 years old, and we document variation in the receipt of care according to the child, family, and system characteristics. And we also explore factors associated with the intensity of the intervention received. We conducted a retrospective cross-sectional design using de-identified data obtained from 19 sites of the Autism Treatment Network and the Autism Intervention Network on Physical Health from 2008 to 2013. The ATN-ARP collect the information on the intervention received, whether behavioral or educational intervention. Parents also asked to report how many hours of intervention that their child received in the past week, in addition to what type of intervention or educational services they received. And the data was collected when they complete the form as the baseline visit. So we derived the study sample using the date on the baseline visit as the index date to identify the sample of children aged less than 6 years old by the index date. And we categorized them into two groups, aged less than 3 years old or referred as toddlers, and 3 to less than 6 years old referred as preschoolers. And then we look at whether or not they receive any intervention. if parent reported that their child received some intervention, and then we sum up totaling the number of hours of combined services received that parent reported, and we categorize into low intensity and high intensity. We use the cutoff point of 15 hours per week. The number is arbitrary. We chose from the review from ARC on behavioral intervention. On the literature that they reviewed, the study that they review report the intervention provided on average of 15 hours per week. However, it's important to address that the high-intensity term we used in this study was not equivalent to early intensive behavioral intervention. It just referred to the quantity of combined services received. And on the parent-reported form on different intervention, there were 12 different interventions asked the parent if their child received the following intervention. And we exclude students who reported receiving intervention but did not report number of hours in the analysis. So we use multivariate logistic regression to predict utilization of any intervention and high-intensity intervention. And we check model specification error, we check model fit, and we also calculated the area under the ROC curve to look at predictive ability of the models. And we adjusted standard error for clustering effect from different ATN sites. ATN ARP also has a lot of other critical measures, including also patient-reported outcome measures. So we include the most frequent report and important ones in this study. The first one is the ADOS severity score, the child behavior checklist, the Vineland 2, cognitive ability. We also look at the quality of life that generate from pediatric quality of life inventory, and also sleep problems reported from parents from the children's sleep habit questionnaire. So we identified 2804 children aged less than 6 years old, and 20% of the children were in the toddler group, and 17% of in the toddler group did not receive any intervention, and only 11% received high-intensity intervention of received equal or greater than 15 hours per week of combined services. For the preschooler, we have a bigger sample size in this group, and we found that 21% did not receive any intervention, and 19% received equal or greater than 15 hours per week of combined services. This table looked a little bit busy. Sorry about that. This table presents characteristics of the study sample in both toddlers and preschooler group. So as you know, the typical characteristic of children with autism, they were male, and we found the majority were white. And when we look at the ADOS severity score, ADOS severity score for the toddler group, the age less than 3 years old, you can see that the ADOS severity score were very similar, whether it doesn't matter whether or not they receive intervention or not. However, in the preschooler group, preschoolers who receive high-intensity intervention had higher ADOS severity score when compared to the group who did not receive any intervention. And when we look at the before I go to parent education, I also want to point out about cognitive ability. We have a large proportion of toddlers who had the IQ score equal or less than 70, and about 50% of the preschooler group that had cognitive impairment. And I would like to point out on the parent education level, you can see that children in the group that did not receive any intervention, there are larger proportion of parents that had high school diploma when compared to children in a group that received high-intensity intervention. And we also observed the same pattern of the distribution of parent education level in the preschooler group as well. And also important point that I want to mention in this slide is about clinical measures and patient-reported outcomes in terms of problems and behavioral problems of children in the sample. You can see that the score are very similar across clinical measures and patient-reported outcome between the group who did not receive intervention and the group who received some intervention. So clinical measures are not different. And this table shows a lot variation of the intensity of services received between the group who received low intervention and the high intervention. On average, on average, in the group who received low intensity intervention, the average hour was only 4 hours per week. When you look at the high intensity intervention group, for both age group, toddler and preschooler, they receive a lot more hours per week, about 20 to 25 hours per week more when compared to the group in the low intensity group. And a most frequent service that parents reported for both age group was speech therapy. And we look at the number of hours that drive the total number of services received on high-intensity group. You can see that behavior therapy, other behavior interventions, and learning center or resource room that drive the number of the total in the high-intensity group. And it's very similar in both age groups. In addition to the three services, Autism School also have been reported in higher number in the preschooler group. In this table, I just want to show the predictors for utilization of any intervention. For the toddler group, there's not many things in there that show significant except for the prior diagnosis. But for the preschooler group, male and white were more likely to receive any intervention. And also parent education, parents with more education are more likely to have their child receive any intervention. For the predictor for utilization of high intensity intervention, parent education appear to be significant in the toddler group, but only in parent with a graduate degree. But for the preschooler group, male still significant in the model, that more likely to receive high intensity intervention, and also parent education still significant in the model. In addition to the previous table, for predictor for high-intensity intervention, the CBCL total T-score or behavioral problems become a significant factor here. The more problems the child have, the more likely that they would receive high-intensity intervention. When we look at variation across ATN sites, because we got the data from 19 sites, we look at the predicted utilization across the ATN site. We did not see variation on the receive of the any intervention. But when we look at predicted utilization of high-intensity intervention, we see some variation across ATN site, ranges from 16 to 30%. So I would like to summarize the key finding in our study. we found that 20% of children with autism in this sample did not receive any intervention prior to their baseline visit. And clinical measures, interestingly, could not explain the difference in the intensity of intervention received. And as I mentioned in the first table about the ADOS series score for children with no intervention services are very similar to children who receive interventions, suggesting that may be a significant number of children who did not receive necessary services in timely manner. Toddler and preschooler that did not receive any intervention were more likely to have parents with high school diploma or lower, and were less likely to be white. And also, clinical symptoms may be associated with whether or not children receive high-intensity intervention. And also, as I mentioned about the variation of predicted utilization of high-intensity intervention across ATN sites, it suggests that maybe geography may be another influential factor in who would receive services. Also, another point between the group of children who receive low intensity and high intensity, the number of hours are vastly different. The group who received high intensity intervention spend 20 hours more per week on different intervention compared to the low intensity group. And these differences cannot be explained by different clinical characteristics of the child, suggest that the need for more guidance for a recommended level of early intervention for children, and also quality improvement programs are needed to ensure that children receive recommended services. There's some limitation in our study. As you know, this is a retrospective database study. They are prone to have recall bias on services used because parents asked to report back to what services received, how many hours. So, and also it's likely that many children began to receive services following the baseline visit, and we would have found more proportion of children who receive intervention, however we did not have the information. And also, again, high-intensity term used in this study referred to only the quantity of combined services. It's not equivalent to early intensive intervention based on behavioral analysis. And also, the models that we look at may have endogeneity issue, especially on parent education, because parents with more education, they're more likely to maybe notice about the cognitive, early impairment, and actively seek diagnosis and seek treatment after the child receives diagnosis. In summary, the use of low and high intensity intervention vary according to the child, family, and system characteristics, and more research on utilization in relation to health outcome is warranted. And as it could lead to recommendation for a specific treatment that specific to clinical characteristic of the child, and also strategy to identify additional methods for capturing utilization of intervention across two systems, medical and educational system, could improve the fidelity of the utilization measures. Thank you.
Great, thank you very much, Mel. So, switch around here. Wow, it's different up here. Okay. So I'm going to be talking today about the effects of Medicaid waivers. I probably should have added the word autism, because there are other waivers other than autism waivers. Effects of Medicaid autism waivers on unmet needs and labor force participation among parents of children with autism. So just a little bit, if you guys aren't familiar with autism, a little bit about what it is. It's a pervasive developmental disorder. It's characterized by repetitive behaviors and delays in social interaction and in communication. symptoms typically appear by age 3, although can be observed and diagnosed as early as in the first year. And it's a chronic disease with no cure, so it continues all the way into adulthood. There's quite a broad range of autism, leading to the term Autism Spectrum Disorder. And it actually used to be that there were different conditions. You've heard of Asperger's disorder, maybe Rett's disorder. But in the latest DSM-5, all of these were kind of collapsed into one diagnosis called Autism Spectrum Disorder. And it can include a very wide range. So you can have kids that are, very severely impaired and really are not able to function out in society, can't hold a job, can't go to school, those sorts of things. Or you can have fairly high-functioning kids who, just seem a little quirky, but are otherwise able to, to function in society. There's also been a huge increase in the prevalence of autism over the last 20 years or so, leading many to worry about an autism epidemic. I think it's a little unclear whether this is a true increase in the prevalence of the disorder or if it's just kind of heightened awareness and kind of a broadening of the diagnostic criteria. But that's a debate that still goes on today. So treatment for autism, we don't really understand very much about what causes autism, so that we don't have a cure. But there's lots of evidence to suggest that early treatment is beneficial. So if we can get kids identified and into treatment early, they can have much better outcomes in terms of educational attainment and adaptive functioning. Treatment typically involves behavioral interventions, many of which can be quite resource intensive. So the most kind of well-known is something called applied behavioral analysis, which is anywhere from up to 25 hours a week with a trained master's level clinician, and it's quite intensive. And then kids can also get psychotropic medications to manage some of the side effects or some of the symptoms that come along with autism. So there's antipsychotic medications that are FDA approved to treat agitation, for example, in kids with autism. Unfortunately, our system of care to treat these kids is quite fragmented. Kids can receive services in traditional healthcare settings, in the educational system, and sometimes even residential care as they get older, more difficult to control. Sometimes they have to be placed in residential treatment. And this can create challenges for families in terms of identifying services that may be available for them in the community and then accessing them. And then unfortunately, the insurance landscape has not been very helpful either. Traditionally, until recently, private insurance has limited coverage for autism. The argument is that it's a developmental disorder, not a medical condition, so it's really up to the schools to treat and not a health insurance issue. The problem with that is that by the time most kids enter the school system, that opportunity for early intervention and treatment has already passed. So there have been some policy initiatives over the last several years to try and deal with this. One is state mental health parity laws, which there was just a session before this one that talked about that. Some states include autism in their definition of mental health, but unfortunately others do not. So, and then there have been some state health insurance mandates that require private insurers to cover autism services. And Colleen Berry, who's standing in today for David Mandel, is going to talk about some of their research in that area. And then on the public side, Medicaid actually offers pretty good benefits for autism services. They often cover services that private insurance will not, things like respite care and caregiver support and training, things that previous studies have shown to be effective in reducing some of the burden of autism. But unfortunately, Medicaid is only available to individuals and families with limited resources. That's for the most part, anyway. I'm going to be talking about some policies that have changed that. So as a consequence of kind of the difficulty in getting access to services and the challenges to families, this often creates labor market issues for parents. So coordinating services takes time. It's really a challenge to try and get kids into treatment. I think some of the results that Nan presented, might be, with respect to the education component, may be reflective of that. That it really, you need to be able to navigate the system quite well in order to get kids into care. Interventions can also involve quite a bit of parent and family participation, which can take away from labor market time. So it's not surprising that previous studies have shown that parents have, in fact, been more likely to reduce hours worked or have even stopped working altogether. And this can just make the financial burden even more acute. So in response to some of these pressures, several states have passed Medicaid home and community-based services waivers to cover autism services. So these were made possible by the 1981 Omnibus Budget Reconciliation Act. And these waivers are used to expand both eligibility, so kids who might not normally qualify for Medicaid can get into Medicaid services just on the basis of having the diagnosis of autism. And it also could expand services, so offer services that's kind of above and beyond the standard Medicaid benefit. States have quite a bit of flexibility, though, in how they structure these waivers. The only requirement is that they target individuals at high risk of institutionalization, which is certainly true of kids with autism, and they must be cost neutral, which means that the value of services provided under the waiver can't be any higher than what it would cost to institutionalize the individual. But we know very little about the effects of these policies on access to care, in other words, unmet needs in these kids, and labor market participation in the parents. So how effective are they at reducing kind of the burden of autism? So the objective of this study, and actually I'm cheating a bit, I'm going to present to you two studies that we're doing, or results from two studies that we're doing. We're going to look at the effects of these autism waivers, and specifically the characteristics of these waivers on unmet needs of children with autism and the labor market participation behavior in their parents. So our data come from two main sources. The first is survey data, and we're going to get data from both the National Survey of Children's Health and the National Survey of Children with Special Health Care Needs. Both of these are random digit dial telephone surveys meant to assess the health and well-being of children 17 and younger. Not surprisingly, the National Survey of Children with Special Health Care Needs focuses just on children with special health care needs. So it's a smaller sample of the entire U.S. Kid population, but it has a particular focus on ASD. And it has some different questions as well, so we took advantage of that. So in the NSCH, we're going to use data from the 2003, 2007, and 2011 waves. And then for the NSCSHCN, which is really difficult to say quickly, by the way, we're going to use data from the 2005, 6, and 2009, 10 waves. So our outcomes for the unmet needs outcome, we're going to use data from the NSCH, which includes the question, during the past 12 months, was there any time when your child needed health care but it was delayed or not received? And then for the labor market participation question, we use data from the NSCSHCN, which includes the question, during the past 12 months, has a family member stopped working because of the child's condition? And then the other source of data for the study comes from a systematic review that we did of these autism waiver policies. So what we did is we scoured the internet, the CMS website, and state Medicaid websites to identify all waivers, autism waivers that explicitly include children with autism in their target population. And we found 50 current or former waivers across 29 states that met those criteria. And then we gathered as many of the kind of source documents for these waivers that we could get. And that involved, again, combing websites, even calling states, begging them to go into the basement, look through the boxes, and find the original application for the waivers. We had mixed success with that, as you might imagine. But we did receive, or were able to obtain over 200 waiver-related documents. And from these documents, we constructed a bunch of characteristics describing the kind of the generosity of these waivers. And 3 of them that we're going to use today in this study are the estimated cost, which is the kind of expected cost of an average person who might be expected to participate under the waiver, the cost limit, which is the maximum amount that can be spent on any one person who participates in the waiver, and then the enrollment limit, which is how many people can be served under the waiver at one time. So for our study sample, not surprisingly, we included families with a child with autism. That was kind of our cases. And then we wanted a control group for each of our outcomes. For the unmet needs analysis, which uses the National Survey of Children's Health, we used just families that had a child without autism as our comparison, so just everybody else. In the labor market outcome, though, we used data from the National Survey of Children with Special Health Care Needs. We thought including everybody else was too heterogeneous a comparison group to really know how to interpret our results, so we thought we should pick a specific condition as our comparator, and we chose asthma. And then our sample included 11 states that had child-only waivers, as well as 24 control states that did not have an autism waiver. And then we excluded the 16 states that had a waiver that targeted both children and adults. And the reason for that was in the waiver documents that we had, we couldn't tell what services were going to go to adults versus what services were going to go to children. So we really had no way of constructing our kind of waiver characteristic variables, at least not in a reliable way for those states. So we felt it was a cleaner analysis just to exclude them. So for our analysis, we estimated these models separately. So we looked at unmet needs, and then we looked at labor market participation separately. For each analysis, though, we did pool the survey data across the years and normalize the waiver policy variables. So first, for the enrollment limit, we divided by the number of children in the state, so we got kind of a rate at which for the enrollment limit. And then for all the policy variables, we normalized them to be a mean of 0 and a standard deviation of 1. So in the results I'm going to show you, the marginal effects are for a 1 standard deviation change in each of the policies. So then we used logistic regression, in which the unit of observation was the child year, and we included then the waiver policy variables, child characteristics, age, sex, ethnicity, race, and then some family characteristics, household income, whether English was the primary language spoken, and number of children in the household. And then the models were estimated using probability weights consistent with the survey data and cluster robust standard errors, cluster at the state level. Oh, I should mention we also included state level fixed effects in our logistic regressions. And then we included interaction variables to do a quasi-triple difference design. So the difference in difference allows us to look at changes in the waiver policies across states with and without waivers in families with a child with autism versus families with a child without autism. And we call it a quasi-triple diff because the waiver policies are not dichotomous difference in these variables. So here's some information about the waivers themselves. These are waiver numbers, not patient numbers, just to be clear about it. So in 2003, there were 2 waivers in effect that met our criteria, Maryland and Wisconsin, and that increased over time to 11 waivers, or 11 states in 2011. And then I've listed here the mean and standard deviation of each of the policy variables. And you can see there's quite a bit of variation in these measures, both over time. So for estimated cost, it goes anywhere from $17,700 in 2005 to a high of $49,000 in 2003. But there's also, if you look at the standard deviation, within any 1 year, there's a lot of variation between states. So that's a nice thing for people who are estimating models. Lots of variation is a good thing. But from a policy perspective, you might scratch your head a little bit. Is this really good for kids and families with children with autism? We see similar kind of patterns of variation in cost limit and enrollment limit as well. So here's some characteristics of the sample. This is for the stop, whether your parents had to stop working. And it's kind of a busy slide, so let me just kind of walk you through it a little bit. So this is our outcome. Did a parent have to stop work because of the child's condition? And you can see it's about 37% in the autism sample compared to 12% in the asthma sample. So it's a much higher rate at which parents need to stop work. We didn't see differences, though, with respect to whether you lived in a state that had a waiver across these 2 groups. We did find differences in the sex of the child. So autism, as Melon mentioned, is much more common in boys than it is in girls. So this is not unusual that we see this difference. We saw small but statistically significant differences in the distribution by age, with the autism sample being slightly younger. We also saw moderate differences by race. So about 3/4 of the sample, the autism sample, was white non-Hispanic compared to about 2/3 of the asthma sample. And then we see pretty big differences with respect to insurance coverage. So 52% of the autism sample was enrolled in Medicaid, whereas about 67% of the asthma sample was privately insured. Here's the kind of same slide for the unmet needs analysis. I won't walk you through it in the same level of detail, but again, just to note that top line for unmet need, it's about 20% for the autism sample compared to 6% in the no autism sample. So we do see significantly higher rates of unmet need in the autism group, with kind of the characteristics, differences in the other characteristics are fairly similar as in the labor market results. So these are our logistic regression results. Again, I don't present them all. I just kind of I cherry-pick the ones I thought you might be interested in, at least the ones that I find interesting. So let me, again, kind of walk you through this. Start at the bottom panel. So here we see that the effect of, being in the autism group, it increases your odds of stopping work by a factor of 5. If the child is female, it actually reduces the probability that a parent will stop work. And we see that if your child is in the younger age group, you're more likely to stop working. I think all of these kind of make sense. If you're, younger child you're not in school yet, it's more kind of demanding on the parent to try and find these services and get them into care. So these results kind of made us feel comfortable that we were measuring it the right way. And then the top panel shows our triple dip policy effects. And the only policy variable that came out as being statistically significant is the cost limit. So 1 standard deviation increase in the cost limit reduced the odds of a parent having to stop work by 0.83. But we thought there might be differences by household income. And in fact, when we stratified by household income, we'll go the right direction here. There we go. Sorry about that. We looked at households with incomes less than 200% of the federal poverty level. We find the same effect as we saw before, where the cost limit is the statistically significant effect. It's a little stronger than it was in the overall sample. But when we look at the upper income households, those with incomes over 200% of the federal poverty level, cost limit is no longer statistically significant, and it's the enrollment limit that has the main effect, reducing the odds by 0.74. Unfortunately, we found that not having a waiver also reduces the odds of having to stop work, which made us scratch our heads a bit. I think, as you start to kind of carve out all these, subgroups, and your models start to behave a little erratically. So I think this is one of the things you might be able to chalk up to, our model being just barely powerful enough to detect these effects. But again, we thought this kind of made sense. If you're in a lower income household, you're more likely to be eligible for Medicaid services already. So it's the cost limit that may be more relevant, whereas if you're in an upper income household, you're only going to get the benefits of the waiver if you get a slot. So it's really the number of slots available that's the most important factor. We saw some similar results for unmet need, where you see cost limit being statistically significant. Here it was we didn't see it in the really low income households, just in kind of that middle group of 150 to 400% of federal poverty level. But again, saw the enrollment limit was the statistically significant effect in the upper income houses. So lots of limitations to this. First, we excluded states that had adults with autism that were included, so we worry about generalizability. Our survey data only go through 2010 and 11. There's been actually quite a bit of waiver activity since then. We're relying on parent self-report. And then you can't tell actually who participates in a waiver. You can tell their household income, and you can see whether they're insured with Medicaid. So you can kind of infer that, that must be in a waiver then. But, that's an inference. It's by no means verified. And then we have no information on severity of illness. So as I mentioned before, there's quite a wide range. You might imagine these policies would be more important for the more severely ill kids. And then there's a question about policy relevance. So the policy landscape for autism services is changing quite dramatically. So in 2014, CMS issued a bulletin clarifying that behavioral treatment for autism is actually included under the standard Medicaid benefit. So then waivers really aren't necessary to offer behavioral services to kids who would otherwise qualify for Medicaid. But I think that there's still a lot of uncertainty around these kinds of policies, and certainly I think one of the benefits of this study is that we don't look at whether there's a waiver, yes, no. We also look at the characteristics of these waivers, and I think that there's a lot we can learn from looking at what characteristics seem to be most effective at reducing kind of the burden of autism in terms of how are we going to structure services as Medicaid expands under the ACA, and how do we extend coverage to people who wouldn't otherwise be eligible for Medicaid. All right, so I'm going to wrap up here because I think I'm out of time. But parents of children with autism are more likely to have stopped working than parents of children with asthma. And children with autism are also more likely to have unmet health care needs than children without autism. But luckily, Medicaid waivers are effective at potentially alleviating these burdens, but the features of the waivers are critically important. So that's it. I want to acknowledge my co-authors on this and funding from the NIH. Thank you. So now, playing the part of David Mandel, David had to be called away earlier than expected, so we're very pleased to have his co-author on the paper present to us today.
This is a tall person podium. It's hard to peer over to see all of you. So, yep, I'm not David Mandel, but I'm pleased to be here today to talk about our study. The title of our talk, as this slide states, is the effects of autism insurance mandates on treated prevalence of autism. And we're now just beginning to dig into some outcomes related to utilization and spending, as well as effects on treated prevalence. So I'm going to preview some of those preliminary results in my presentation as well. We have a fantastic study team that's been working on this project, and so I want to acknowledge our wonderful collaborators, and I am grateful for funding for this work from the NIMH under multi-PI R01 that's led by me and David. Let me just very briefly, I'm going to, the prior presenters did such a great job providing some of the contextual environment both around what ASD, Autism Spectrum Disorder, is, and also some of the sort of challenging issues that are connected to our approach to trying to provide services to try to help individuals with autism spectrum disorders in terms of improving their well-being, functioning levels, and so I'm not going to repeat that, but rather try to put this sort of basic information that we know about increasing prevalence rates, the quite high costs often of treatment that are sustained and intensive and thus quite expensive, and the resistance on the part of commercial insurers is to historically cover treatments for autism on the grounds that they're experimental and unproven. To put this information in the context of sort of the momentum and efforts on the part of advocates to push through safe autism mandates. And in fact, these efforts have been quite successful. We now have laws on the books in 42 states requiring some level of mandate related to the coverage of autism to try to push for a larger role by the commercial insurance market to serve these kids. And so I want to just maybe begin with a little bit of information related to sort of our study design and our approach, and say a little bit about what these mandates are and what they look like in the context of thinking about understanding their effects, which is our goal here. Our aim with this R1 is to be able to understand how these state policies are affecting what we call treated prevalence, which is basically access, the probability of using services under to understand about state mandates passed by state legislatures is that they only affect a subset of the privately insured population in a state. So if you work for an employer like, say, Johns Hopkins, which is where I work, and if that employer chooses to so-called self-insure, meaning to sort of bear the sort of risk-spreading function, then no matter how many in Maryland, where Johns Hopkins has a lot of state mandates, like upwards of 30 different sort of health-related mandates on health insurers, you're not subject to any of them. And the reason why you're not subject to any of them is because of importance and I think sort of in the broader world, not in our sort of rarefied world of health economics and health policy, but in the broader world, a little understood law called the Employer Retirement Income Security Act of 1974, which exempts so-called self-insured firms from state mandates. So only if you work for what's called a fully insured firm are you subject to these laws, which in practice means that among those with private health insurance in a state that has passed a mandate like an autism mandate or a parity mandate or a drive-through delivery mandate, you name your state mandate, only somewhere between 40 to 60% of a state's population that is privately insured is actually subject to that mandate. So only in these states that have passed autism mandates, of those with private insurance, only 40 to 60% of those individuals are subject to these laws. And this has presented a real challenge to researchers in trying to identify effects, because it enters in a lot of noise when 50% of the people that you're expecting to see an effect from are totally unaffected by the policy from a regulatory standpoint. But it creates, if you can identify in data who's self-insured versus fully insured within a state that's passed a mandate, it creates some interesting heterogeneity in policy effects that you can sort of exploit in the context of a research design. And so in states that have passed mandates, these only apply to this fully insured population and not self-insured individuals working for self-insured firms. And in our data, which I'll describe in a minute, we have a flag that allows us to identify at the individual person level who is in a firm that self-insures versus fully insures. The analysis uses commercial insurance claims data, which I'll describe in a little bit more detail, over a 5-year period where a lot of these mandates were being implemented. And our analysis rolls up these data to the child month level. So the unit of analysis for the study purpose is the child month. And in addition to sort of exploiting this sort of variation within states in terms of who's actually subject to the mandate, we exploit this variation in passage of these laws over time. And our basic approach is actually like the meat of it is a triple diff, but we sort of set it up as a difference in difference, a double diff model. So here you can see that states sort of have passed these laws over a relatively short period of time, and we compiled an inventory from Autism Speaks, and then our awesome research assistants went in and for in this sort of painful sort of data collection mode that Doug nicely described in the context of his waiver work, went back to the original statute and sort of made sure that we could verify all of the sort of specific provisions of these laws, including which states, when the mandates were enacted, when they were implemented, and relevant provisions. Like, for example, and we use this actually in our model as well, but like some states only cover kids ages 2 to 6. Other states cover kids 0 to 21, and then sort of in between there's some variation as well. So we pull those details. Some of these states have caps, $36,000 a year cap, that kind of thing. We actually have not incorporated that component into our analytic approach, but we've collected the information. As you can see from this slide that shows which states implemented over our 5-year time period, you can see that states that passed mandates, and this is what I immediately look for in terms of this kind of analysis, that they don't follow any obvious patterns that you can see, at least in the sort of category of obvious observables, such as political ideology or what we know about state supply of medical care services more generally, or autism-specific services. There's no sort of like clear and apparent pattern when you sort of look at these states that hit our study period. Here is in words the basic sort of design approach that we're using. Our treatment group is children who live in states with active mandates who are eligible for that mandate. And we define eligible is getting insurance through a fully insured firm and being the age at that month, at the child month level, where you hit the age eligibility category. And we compare this treatment group of kids to basically 3 other groups. Children in states with an active mandate who are not subject to the mandate for those same reasons. Children in states without a mandate who would have been subject to the mandate if one were active based on working for a fully insured firm and hitting the right age bracket in their specific state. And children in states without a mandate who would not have been subject to the mandate if one were active. And so, some of us are words people, some of us are visual people. Here's the sort of visualization of what I just said. And I want to sort of make 2 maybe subtle points that didn't come out from the prior slide about sort of what this means. What it means, first of all, is the no mandate group includes the never mandate states, but it also includes the states that in that child month had not yet implemented a mandate. So a child, if they stay in the data set over the full time period, will flip at some point, and in a month when their state begins implementing. And also, we don't know, so we know with a state that implemented a mandate that they chose the age bracket 0 to 21. For states that haven't passed a mandate, we don't know what they would have done if they had passed a mandate. So we basically make this assumption, which is that they would have passed a mandate covering the age bracket 0 to 21. So that basically encompasses what our comparison group population ends up looking like. It's a total assumption. We run 1 or 2 sensitivity analyses around it. We look at 0 to 18. We could play around with this more in terms of sensitivity analyses, but it's an assumption we have to make to sort of make this work. So we use insurance claims from 3 national insurers spanning 50 states in the District of Columbia. This is the Healthcare Cost Institute data. It's a really cool data set. And the 3 insurers are Aetna, Humana, and United Health Group. We have this awesome and critical flag for whether at the individual level that individual enrollee child is in a fully insured or self-insured firm. Due to the nature of policy, we exclude kids in individual plans. We critically also have a flag that tells us whether we're observing the full mental health benefit, whether it's carved out from our data or carved in from our data, and we only include, for obvious reasons, kids in our study where we can see all of their medical and behavioral health care service use and spending. And as I said, the unit of analysis is the kid month. We have 154,000 children with autism, which translate into about 3 million child months. And we define autism as a claim of service, utilization of the service with an ASD claim associated with it. And we have a total of about 600 million child months, which created some pretty interesting computational challenges that we managed to overcome. So here are our 3 outcomes. The first, as I say, was the main focus of our first paper. Did a child have a claim with an autism spectrum diagnosis during the given month? This first outcome is estimated by a logit. The 2 additional analyses, which are our new analyses coming out, This is basically a two-part model. Conditional on having ASD, did the child have an outpatient service, any outpatient service use in the given month? The second outcome is also estimated by a logit as the first part of the two-part model. And conditional on having ASD, what was the child's monthly spending on all outpatient services? The third outcome is the net result of the two-part model with log gamma GLM. And so let me note that this is not just autism-specific outpatient spending, it's all outpatient spending. We were interested in that outpatient spending category overall. Although now in our analyses, we're looking at autism-specific spending on the outpatient and inpatient side. Like there are a bunch of important outcomes to look at, but this is where we're starting. So here are our basic models, the unadjusted and adjusted basic models. I indexes kids, S indexes state, T indexes year. The X down here, this is adjusted, includes everything that you can adjust for in claims data, which is not nearly everything that you'd want. But includes child sex, age in the month, insurance product type, consumer-directed health plan status, and calendar month. The next thing we do is we estimate a second set of models, and I'm actually going to focus on these models. They're, I think, pretty interesting, including 3 cohort indicators to examine whether the effects of mandates differed based on the number of years following implementation of the law. So from our qualitative work, what we learned was that states had trouble getting these laws off the ground for all sorts of reasons related to all the implementation challenges we think about in policy making, including just basic issues around credentialing providers. So our hypothesis is that the size of the effect in the if we see an effect, the size of the effect in that first year following implementation may be smaller than what you'd see once a law had been in place for a while. So we look at the first year and we compare that to when a law had been implemented for 2 years and then 3 or more years. And so that's how we set up that model. And then this is super important to bolster our confidence in our quasi-experimental approach. We compare pre-period trends in treated prevalence in all of these outcomes in the years prior to implementation among states that eventually did and did not adopt mandates. And we saw no evidence of differences in trends in treated prevalence and use and spending between eligible and ineligible children in states that never passed mandates during our study period compared with those that eventually passed mandates. And this is this is quasi-experimental research. This doesn't make you 100% confident, but it makes you feel a little better that you're doing your best to sort of pull out the secular trend. So here are the results. The unadjusted sample-wide treated prevalence was 1.7 per thousand. As you can see from this result slide, I'm going to focus first on the top row. The treated prevalence rate among eligible children in states without mandates at the child month level was 1.6, and this compares to a significantly higher treated prevalence rate of 1.8 among eligible children in states without the mandate. As expected, you can see when you look at the bottom row that we find no difference in treated prevalence among ineligible children in either group, and this is a helpful check for us. The adjusted difference in difference result represents a 12.7% higher rate of ASD treated prevalence attributable to the state mandates. Here are the results based on the years of exposure to the mandate that I talked about. Here again, compared with the treated prevalence rate of 1.6 per thousand among eligible children in states without the mandate, we find higher and increasingly high rates of treated prevalence based on the number of years since the state had implemented a mandate. So these translate into adjusted differences in treated prevalence of 10.4% following the first year of state law's implementation, 17% at 2 years, and 18% at 3 or more years. Here is the outcome related to the probability of monthly outpatient service use, and you see here a similar pattern compared to the non-mandate state eligible group, and just focus on the blue lines, although they're relative, importantly, to the green lines. 2.2 percentage points in year 1 3.3 in 2 years following implementation, and 3.7 percentage point increase in outpatient service use at 3 or more years. And finally, here is the adjusted monthly expenditures compared to eligible children in non-mandate states. And in the different DIP framework, we see a higher level of monthly outpatient expenditure. And keep in mind, this is outpatient. I think when I looked at this, I was like thinking in my sort of outpatient and inpatient brain, but it sort of puts this in terms of the true magnitude. About $58 1 year following in differential monthly spending, $113 2 or more years 2 years following implementation, and $150 at 3 or more years. Just a quick summary. So state mandates requiring commercial insurers to cover ASD for children have led to significant and what I would call sizable increases in treated prevalence, but also in the number of children receiving any outpatient treatment and per child outpatient spending. So to put this sort of in the context, take it out of the month and stick it in the year. By the 3rd year following implementation, we identify an average increase of about $1,800 in outpatient spending per child year, often already high spending base of about $4,500. So these kids were already spending quite a bit, and they're spending significantly more in the outpatient setting, attributable to the mandate. The limitations are all of the typical limitations, which is identifying a diagnosis and claims. We weren't able to account for some of these other differential policy attributes of state mandates. The data source is large, but it's a convenient sample, and there's a lot of important outcomes we haven't looked at. And of course, the important point that I would make, and Doug referred to this in his comments as well, the CDC 2014 release of new data identified 1 in 68 children as having ASD. So when we think about in a private insurance market what we're calling treated prevalence rates, it's really a different order of magnitude from what we're seeing in terms of community prevalence rates. Thank you.
Thank you, Colleen. All right, so very pleased to have Ben Cook here, who will offer his comments. Oh, that's wrong. Sure you don't want to know?
All right. We are in the 7th inning stretch. I won't judge if you get up and move around a little bit. 7th inning stretch of like a 20-game series. All right. Okay, well, first of all, I have to say that these were 3 really nice papers. So one descriptive paper that did a really nice job about painting a picture of the correlates of intensive services for autism, and then 2 causal papers that used a nice research design to get at some of these important policy changes. So with that in mind, some of these comments that I have are really going to be things more like to think about. If a reviewer like me gets a paper or some slides like this, there are some things that I might have been confused about. So it's more about clarification, and I'm not going to tell you all you did anything wrong, that's for sure. These are really nice papers. Okay, so I guess I got some kind of animation here that I didn't anticipate. So let's start with Colleen. I'm sorry to start backwards, but all right. So this is an important topic, of course, the effects of autism insurance mandates in 42 states. No commercial insurance coverage for autism treatment means there have historically been 2 tiers of treatment. Right? So that sort of struck me. I'm a bit new to this area, and the fact that there hasn't been commercial coverage for autism treatment is a little bit unbelievable in some ways. So this is expensive if you wanted to do it right. 15 to 20 hours a week is a lot of care, and if you don't have coverage for that, then and if you're in poverty, then you just probably can't do it, right? So this is really important to have these mandates. Intensive treatment can make a large difference. I think there are a number of studies that have shown that. But then on the flip side, these mandates have this issue that it could be really expensive. And what that does for offsetting other costs or the burden that it puts on providers ends up making these policy changes really important to evaluate. And then Colleen and Data Mandel have done this nice job of exploiting this variation in mandate over time, as she showed you that really cool thing where the states pop up one by one, which I love.
Style over substance.
Okay, I don't have to deal with animations. So here's what I think about their diff and diff and diff, which she scaled back to a diff and diff, which was she has that nice variation that she talked about within state, which was the ERISA versus the non-ERISA, and she has the between state, the states with mandates and the state without mandates. And then she has the within state, and I realize now a little bit better that that kind of within state, the pre-mandate implementation, that goes into the kind of control group, right? But, and then IST, there's an IST that accounts for the variation in these repeated measures over time, which is nice. But there might be some unobservable differences that aren't being differenced out by not using that third difference. So the identification strategy will be more conservative, I think, because then you're going to be in a triple diff, and the power is going to get smaller. But there may be some unobservables that you're missing by not taking that third difference and instead putting it into that control group. And those will be important within state differences. I mean, those are kids that will look a lot like the kids within that same state post. And that's the difference that is left out if you're going to keep the different things. So I think that's how that's operating. And it may be that some of the ways in which the specification, it takes care of some of that. But I think at least to clarify that for the reviewer and why this is a little bit different than the triple diff and what you lose by going back to the diff and diff would be helpful. So you've done this nice job of checking parallel trends, and so that's a really big assumption, I think, is that there are these parallel trends. You might do it by some states to show that, as opposed to just overall, it looks like we have parallel trends. Well, it might be helpful for a reviewer to see that this actually is fairly consistent across a number of the states. And then you also want, one thing that's often not talked about for diff and diff is to kind of have this assumption that there would be parallel trends after the intervention, that those parallel trends would have continued after the mandate. And there is this threat that you worry about, which is politics, right? So there's all this advocacy that's going on around getting the mandate going. That might be very different in the different states. And so those advocacy and legislative efforts, sometimes they fail, sometimes they don't fail, and you get the mandate. But you can see how that kind of state time variation advocacy efforts could be driving some of these results at the exact same time as the switch on mandate or not. So at least a kind of recognition, I think, of that possibility. I don't know how you would measure advocacy over time, but that idea that might be a limitation to that parallel trend after assumption. And then another assumption that this identification strategy has is this idea that the composition of individuals needs to remain the same over time. So ideally, you want your treatment and control groups, pre and post, ERISA, non-ERISA. You want those people to be the same. You want those groups to be relatively constant over time. But you don't want big shifts in the makeup of those groups over time, except for the policy. But you have this issue of, there might be ERISA to non-ERISA movements, and I think you could find that out by doing that over time. But you have this increase in the number of youth diagnosed, right? So if you have a mandate, there's going to be a real induced demand in that state to recognize more youth with autism. And that's going to change your denominator for that group in that kind of cell that we're talking about in the different group. And so you are going to have a little bit of an expansion in your N in one of those different groups. And that might, that's an assumption that might be and that's especially true in the conditional analyses that you do, the probability of treatment given diagnosis, the probability of expenditures given diagnosis. So you can get away from that problem by just looking at the full population and doing similar results in the probability of treatment without that conditional. You just have your sample and you don't have that moving denominator. So some implications. So there's sort of this Woodwork effect, maybe. I don't know if you would call it that the same way that ASD called it the Woodwork effect. But you might have some people coming out and real systems changes in the mandated states that do this thing of this induced demand from service providers. There may be coding in the spectrum. So there's sort of this interesting implication that your study draws about the effects of these mandates and what it's going to do for inducing demand in these areas. So I think this is sort of a discussion point that's really interesting. At my hospital, we're scrambling to try and get an autism clinic. We have a lot of autistic youth who are leaving for M.P.H because the services are better over there, but we have them under global payment arrangements, and so we're losing a lot of money across the river. And so you can see how a mandate plus this shift to global payment is really going to change the way that we're thinking about how to provide this treatment and the ways that health service systems like Human Health Alliance are thinking about this. So I think there could be a nice discussion in the end about what the ramifications are for the mandate on those kind of service provider changes, and then our shift to different kinds of payment, global payment for children with autism is going to be a difficult one. How are you going to incentivize that? So as we move towards those kind of payment models, there might be some implications of that. Okay, Doug's paper. So 50, I'm just providing the summary here, 50 current or former home and community-based services waivers in 29 states that explicitly include children with ASD in their target population. This is really important in some ways, given what we were talking about how intensive these services can be. So Medicaid's now a major payer. Doug mentioned in this paper that 45% of youth with ASD are being paid for by Medicaid. He finds a significant impact on unmet need for some of the kind of components of these waivers, as well as parent employment, which is a very significant finding. And he really capitalizes upon the variation in state waivers on estimated cost limits, and enrollment limits. And in the paper, you talk about eligibility criteria and services covered at the top, but that doesn't make it in the bottom. So that's just, I think that you just want to keep that out of the paper. But I had a kind of question about estimated costs and what that's doing. And I think maybe in the paper there could be a way to describe that a little more. It could be sort of a marker of the intensity of services that's provided in that waiver state. It could be geographic variation in provider behavior. It's kind of unclear what you're getting from that estimated cost. I get cost limits and enrollment limits. That's sort of a cap that the state is putting on, but I'm not sure what you get from estimated cost. It might be like an intensity metric, but you can just explain that more. Okay. So you mentioned in the paper something about your weights. There is missing data. You said you re-examined the probability weights after developing this kind of unique analytic sample from this large combination of two data sets. So if there was a need to do some kind of adjustment to the weights or something, it wasn't in the paper, but there could be some kind of inverse proportional weighting or something to deal with the missing that wasn't in the paper that you need to do, or we have that already. Okay, and then I just wanted to touch on your quasi-DDD really quick. So you talk about the interactions of ASD status, waiver policies, and state fixed effects. I think you mean you have from the equation at least, what you have is an interaction of ASD status and waiver policies, and then state fixed effects. If I'm understanding it right, at least from this equation, you don't have the triple difference. You have kind of this double difference by that ASD multiplied by all of those other things. So I think you then are talking about variation within state in your waiver policy, and so you're really requiring that how you standardize those limits now has some variation within the state, which is a nice framework, but I got confused about whether this was a triple difference or how we were using the state effects. So you can really isolate, I think, the identification strategy a little bit more and make it match this equation. That would be helpful. I would borrow from Barry et al. And think about the timing of the waivers. I thought that was a really nice sensitivity analysis that they did. And you had that same issue in some ways. Some of your states have been enacting those waivers for quite a bit of time by the time you get 2011, whereas others are just starting up. And if there really is a starting effect, at least adjusting for it in the model. And then there's a concern about local autism services matching the timing of the waiver implementation. But again, also these advocacy efforts need attention, raising awareness. And there's sort of this waiver effect. And this is, again, kind of one of these possible confounders that threatens your DDD strategy that you just might acknowledge. This is similar to what I said about government. And then you have uninsured and privately insured. This is a Medicaid waiver, and I think that means that there's sort of a spillover effect that you're thinking about. Or in your presentation, you said it was a little bit hard to identify some of the Medicaid individuals. So maybe just kind of being very explicit about including the whole population and what that spillover effect might be. And then the high income families, some of them are eligible. There are slots for them in the Medicaid waiver. I didn't know that. Almost done. Okay, so really quick, I like the presentation in table 4 in your. So I got 2 papers from Doug. I should get double credit for this.
Yay!
So in one paper on unmet need, you have a table 4 which shows the predicted probability of unmet need and shows the waiver effect and then the additional effect of the increase in cost and the additional effect of the additional enrollment limits. It's really nice. You kind of parse that out and you can see that. It would be nice to see that for parent employment. But then it's also important to note, I think, that you worry a bit about the heterogeneity. Like you really reduced a lot of that information into a normalized thing that's got a mean of 0 and 1 standard deviation. So you might lose a little bit of that interesting variation across the different states. So you might think about a figure or something that plots changes by state in real, not standardized terms, so you can actually see the dollars, and so maybe policymakers can get a little more traction off of seeing what this is in real terms rather than standardized terms. And then in your second paper in the employment, you justify the use of. I would ask that you justify the use of youth with asthma. I was thinking that you could use the general population, but then I realized during your talk that you don't have the general population because of the special health care needs survey compared to the national survey. But maybe there are other reference groups that you could use beside asthma. That seems like a very particular illness with its own set of politics and changes over time. So you might think about maybe doing another one of the sensitivity analysis, childhood diabetes or something like that. Okay, so now to Nana's paper. So I was really impressed with the data that the Autism Network has put together on this. The clinical measures make it a really unique data set, and better than the claims and electronic health record stuff that we deal with, because it has these really nice measures.
That's totally true.
And I think it was a really important topic, given the importance of intensive services at an early age. That was news to me that you have 15 to 25 hours a week to improve outcomes with that thing that being really important. So the cost and the intensity of the services are really a big deal in this population. And you do a nice job about raising that, about showing the correlates of who gets the intensive services. So I would have liked to see a little bit more depending on the importance of intensive services. So you put a lot of emphasis on that 15-hour cut. And so that ends up being a really important cut. So that AHRQ report ends up being really crucial in a way to the split that becomes the crucial part of your paper. So you really want to motivate that 15-hour. You know, right away you worry about 15 hours of what, and whether it's quality 15 hours or not. You start to get into that by looking at the different services. But maybe there's a way of combining some of the types of services that we suspect are higher quality with the number of hours in order to get a kind of better idea about the quality of care. There's sort of a denominator issue here, I think, but I don't know who gets into the network. So there is this probability of any intervention, which is a main dependent variable that you have. Well, in order to get into the autism network, what do you have to do to get there? Is it anyone in the community? You see what I mean? So there's a national sample, and then there are a smaller sample is the autism network, and then the smaller one of that is the probability of any intervention. But it's really important to know what the autism network is compared to the national sample, so that we get a sense of what the probability of any intervention means. You need to know something more about the probability. You adjust for these rich clinical need variables, and once you do that, you say that, look, it looks like the clinical need is quite similar between those who got intensive and non-intensive. So I would make that a big part of your analysis. I mean, that's really interesting. Rather than simply adjusting for it, I'd stratify by some of this high need, low need strata, and then you can really dig in and see whether you have some of these education differences that are really important, whether they kind of persist in the really severe need. And then I would help us think through the different types of interventions. You have that nice list of speech therapy, occupational therapy, tutoring, etc. Some better than others. Is there an index that you can create based on people who do these autism services in terms of what's really important versus what's not as important, and then give some kind of valence or context to all of those services that you have related to autism. Again, getting at this idea that there might be a quality indicator rather than just types of services and number of hours. Maybe there's a way to some other kind of that. And then you might add a discussion about recommendations for payers, given this big income